Welcome to Value-Based Care Insights, brought to you by Lumina Health Partners, a national healthcare consulting firm focused on improving the strategic, financial, and operational performance of provider organizations. On this program, we will explore trends and share valuable insights on how health systems and medical groups can optimize their performance to meet the demands of this increasingly complex healthcare environment and shift to transform the delivery of care. Value-Based Care Insights is hosted by Daniel Marino, Managing Partner of Lumina Health Partners. Daniel has been in the industry for over 3 decades and specializes in shaping strategic initiatives for organizations in areas such as population health, clinical integration, physician alignment, information technology, and data analytics. For additional insights, visit luminahp.com and sign up for our newsletter. Dan, over to you.
Welcome to Value-Based Care Insights. I'm your host, Daniel Marino. In this edition of Value-Based Care Insights, we're going to explore some of the challenges that are occurring in rural healthcare. Rural healthcare providers are facing enormous challenges in being able to deliver the right level of care at the right time to patients in their community. And there's been a number of organizations who have been fairly creative on thinking through how do we deliver that right level of care, still make ourselves economically viable within our community, and really serve the needs. Well, today I am pleased to have with me the CEO of Great Plains Health. Great Plains Health is in North Platte, Nebraska. Ivan Mitchell is the CEO. He's been with the organization for about 7 years, recently has taken over the role of CEO. Prior to that was COO for a good number of years and has done a great job in supporting the organization, aligning with its physicians, and really positioning the organization for success. Prior to that, Ivan had led another organization in the rural healthcare market, so brings a tremendous amount of experience. Ivan, welcome to the program.
Thank you, Dan. Great to be here.
So, Ivan, maybe if you can spend a couple of minutes on what are you seeing right now as some of the major challenges for Great Plains Health as you continue to position it for success and serving the patients, serving the community.
Well, great. Well, thank you, Dan. Well, right now there are three major challenges, and 2 are kind of intertwined with one another. You've seen the reports out there that about half of the hospitals in the country will have a negative margin this year, and so margins have really been crunched. And I bring it down to three areas. Number one is the workforce and the labor shortage. The amount of money that we had a shortage of, and mainly nurses. We'll talk about that, but we had a shortage of nurses prior to the pandemic. I think the pandemic really exacerbated that shortage.
Yeah, I agree. Across the board.
So we're basically kind of left with the decision of, if we keep a service going at the level that we have in the past, we're paying just extremely high agency costs, sometimes 2 or 3 times what we were paying before the pandemic, and it kind of feeds upon itself. So that labor shortage has been the biggest issue. I would say the second largest issue is somewhat intertwined with that. And we are not a critical access hospital. We're a 116-bed PPS hospital. So essentially, we get paid per admission. We don't necessarily get paid per day. And so if someone comes in for pneumonia, your average pneumonia stay is 3 days. You get paid a DRG payment, a diagnosis-related group payment. So let's say that Medicare gives you $5,000, whether that patient stays 3 days or 30 days. And so we've had a significant amount of patients we've had patients over 100 days in our hospital. And so it's been difficult, especially a lot of those patients that you're dealing with have some major social and sometimes behavioral issues. But that length of stay, if you think about it, it costs quite a bit of money to staff a hospital bed, with the nurse, the meds that you give, the meals, and essentially all the care that you provide that has to be provided at the hospital level. is pretty significant. So if your length of stay goes from an average of 3 days to 4 days, you just increased your cost 25%. So
yeah, absolutely. Yeah. And you're not getting the revenue in there because the DRG is pretty much set. So I can see that being a major challenge. And then, as you've said, exacerbating that even more is the high cost that you're paying for, say, agency nursing support and some of the other supply inflationary costs that are inherent in the organization.
Yeah, and we've been tracking, and we basically sit at about a dozen patients every day that no longer meet acute care status. So
yeah,
it's a fair amount of our inpatients that are in that situation. So it just you have some major cost pressures there.
Yeah.
Now, if you are in a critical access environment where you're paid cost based, it seems like at the hospital association level and whatnot, it seems like the critical access hospitals are, they're still having their own challenges, but
sure,
they aren't dealing with that one, and they're doing quite a bit better, I think, financially overall than the PPS hospitals are this year.
So, given the financial challenges that you've had, and even with in your organization, and then certainly within the critical access hospitals, have you started to align a little bit more with them?
Yes, we've partnered really closely with them for a long time, for as long as Great Plains Health has been in existence. And it seems like a lot of the time, the larger hospitals in the region, they strive to, a lot of them will strive to take business or volume out of the small community and take it to their large facility, because then they're obviously getting both professional and technical fees, and that seems to be the way to kind of maximize financial revenue. We take a little bit of a different approach here at Great Plains Health, and we kind of turn it on its head, and we tell our specialists to go out to the facilities around us, and then we even encourage them to do everything that they're comfortable doing in those communities. Now, some of those communities should not be doing everything. There is definitely not some higher level surgeries and things like that, but we tell our orthopedic surgeons, if you're comfortable doing surgery there, go for it, do it.
Right. Well, and you're just supporting it's frankly, I think it's better patient care, right? I mean, instead of having the patients drive 80, 90, maybe 100, 120 miles, which is not uncommon, to be able to have that care closer to home, I think helps all the way around. And if you can create the right incentive model for the surgeons or for the physicians to support that, maybe, certainly not going out there every day, but once a week or once every other week or something like that, that's a tremendous value add.
Yeah, I agree. And, I think the patients it's always easier to recover closer to home. Your family can visit you, and I think it's just the right thing to do. Our oncology program is one of the more impressive ones, where we send our oncologists all throughout the region, and our service area is about a fourth of the state of Nebraska, and we even go into a little bit of northwest Kansas, a little bit of southern South Dakota, eastern Colorado, and we have a good telemedicine program set up where we'll have a physician go to a hospital once or twice a month, but then we will see those patients through telemedicine the rest of the month. And
that's great.
Yeah, they'll continue to get their chemotherapy infusion treatments in those facilities that are in their hometown, versus having to, like you said, drive an hour or two to come see us.
So in working through that, then with the specialty, particularly with cancer, telemedicine and virtual health, it sounds like, is a pretty big part of your care delivery model.
It is, yeah. I would say that Great Plains Health was really innovative even before the pandemic with telemedicine, not only receiving some services, but then also sharing some of our specialty services with the region. And I kind of use the analogy, it felt like before the pandemic, we were kind of trying to push a boulder up a hill and convince people to use telemedicine. And when the pandemic hit, innovation a lot of times will happen during difficult times or traumatic times. And so then everyone jumped onto it, and it was people were coming to us wanting to do it, and so that made it,
well, sometimes disruption like that is the best way to push innovation forward, right?
It is, yeah, it is. Prior to the pandemic, we had, our town is about 25,000, our county is about 40,000, but the fourth state region that we cover has about 100,000, in that population. And so for a town like us, for example, nephrology, we could probably accommodate 1 to 2 nephrologists. And they say the average physician is getting 2 job inquiries per day.
Wow.
Because of the shortage. So if you're a nephrologist, you're probably not going to want to go somewhere that you're on call 24/7, 365. And even when you're not technically on call, you know how this works. A colleague will say, "Hey, I just got a quick question for you," or they'll send you a quick message, and so you really can't get away. So we had partnered with, at the time, we had a group out of Utah that was doing telenephrology for us. We've since partnered with an organization in Nebraska, Bryan Telemedicine, that provides the telemedicine services. But
that's great.
We had nephrology, neurology, and stroke. We had pulmonary critical care. We had infectious disease. So we had all of that in place before the pandemic. And so when the pandemic hit, we had a process, we had a system in place, and it was very easy just to kind of move that along and get that moving.
Yeah, that's fantastic. And I'll tell you, that's just such a big value add when you're taking care of patients across a region, right? To be able to really use and utilize that technology within the care model, I think has a tremendous amount of value add. I want to talk a little bit about your physician alignment strategy. You had referenced that, mentioned that, physicians are getting inquiries from other organizations based on certain specialties. It's pretty competitive out there. And you've got a pretty good model that includes both employment, but then integrating with your independent providers. How's that worked for you in supporting your strategy and care delivery within the system?
Well, I think it's gone very well. We have, with the help of Dan Marino here, we have set up a clinically integrated network. And so essentially allowing the physicians in our region, both employed and independent, to negotiate directly with insurers as a group, and
right.
And then focus on value-based agreements. So that's what we've done. When I started about 7 years ago, I think our mix was probably about 40% of our physicians were employed and about 60% independent. Now we're probably about 70% employed and 30% independent. So that transition has come.
Yeah.
We tell our physicians that you're welcome to, if you want to be employed, you don't want to deal with billing, with management, with personnel issues, we'll take care of that for you. You're welcome to be employed. If you want to be independent, we'll support you however we can with your independent practice. And if you become employed and then later decide you want to be independent, we'll help you become independent. And so we just leave it up to them. I think that from my perspective is that there's a lot of trust with our physicians and our leadership. And so I think that's why you've seen more that have gone the employed route and just have kind of taken some of the headaches off their shoulders. But I feel like it is kind of circular. It seems like right now the regulation, the legislation and stuff is promoting more of the employment model. I wouldn't be surprised with changes in administration if that shifts and people are moved back to independent practice. Right. And we just want to be a good place for our physicians to work, so we will support either model.
If you're just tuning in, I'm Daniel Marino, and you're listening to Value-Based Care Insights. I'm talking today with Ivan Mitchell, CEO of Great Plains Health, and we're discussing some of the challenges that are occurring today in rural healthcare. And kind of building on what you had just mentioned, I give you a lot of credit for that. The relationship with your providers and really supporting the physicians, whether they're independent or they become employed, obviously is really critical. But a big driver of that, right, is the economics and the financials that come through, particularly on the revenue side, do you feel like the payers that you're working with right now, do they understand some of the challenges that you're working through and your physicians are working through and serving the needs of the community?
Personally, I think they understand it. But in a lot of ways, the incentives between the organizations are kind of malaligned. And
No, I agree with you. And that's a big point. I've talked about that many times on the program here, that the incentives of the insurance carriers and the plans don't necessarily align with a not-for-profit health system, and certainly a rural healthcare provider like you all. I think it is a bit of a challenge. But go on. I'm sorry I interrupted you.
No, that's okay. So I'm obviously team hospitals, and
Right.
the average S&P rated hospital has a 3.83% profit margin, or at least that's it's going to be interesting to see what it is for 2022. I'm guessing it's going to go down quite a bit from there. But in my mind, you look at pharmaceuticals, medical device, and insurance companies, and whether you like the Affordable Care Act or not, they had to cap insurance profits at 20%. And so
Sure.
because they had to cap that, that tells you that, it was quite a bit higher than that. So and then you'll see some pharma industry and some companies that'll have 300-400% profit margins. And so healthcare is grossly unaffordable. And as a hospital, we absorb these costs from pharma, from medical device, from insurance, and then we end up collecting from the patient. So the patient hates us. But I think when you follow the dollar, I feel especially the nonprofit community health systems are kind of the good player in the market. But the way that this is set up is most people hate us. So it's a little frustrating in that regard. But I'll give you a couple of examples. Blue Cross Blue Shield in Nebraska, they're going to start paying 50% for telemedicine. And we basically kind of shared with them what we shared with you with our oncology practice. And we said, hey, this is very, this is not rural favorable. And we can use those examples. And the person we're talking to obviously can't make changes at the high level. They can just kind of move it up. But they don't do that. The other issue that we're having some struggles with is white bagging, where it'll delay a patient getting a specialty med, sometimes more than a week. Right. And the model that we try to put out there, we really like. We try to get the physician to establish a relationship with the patient locally. Mm-hmm. So yes, that's the white bagging issue, where we keep pharmaceuticals on hand. We have to store them in an appropriate way. We have licensed pharmacists that have to take care of it and do all this work. And then an insurance company says, well, you can't get the med from that hospital. We're gonna delay this, a couple of days while we ship something in from, another pharmacy. And then you guys who have absorbed all the fixed costs are going to have to go ahead and give it to them, and we'll give you a $50 administration fee.
Right. And that just doesn't work.
It doesn't. And the reality is it's basically taken the profit from the hospital to the insurer, who already has a much higher profit than we do. And then our hospital, for example, we are 70% Medicare, Medicaid, or uninsured. And so essentially we have 30% of our patients making up the difference of the other 70%. And so when you commoditize healthcare and you take services out of the hospital and take those margins somewhere else, essentially what happens is the cost for the 30% of the people that we have here in the hospital, those have to increase to cost shift and make up the difference for our Medicaid, for our self-pay population. Yeah. So,
or you're really faced with a situation where you have to cut services, right?
Yeah, exactly. And
can't afford it.
And we're required to provide care regardless of someone's ability to pay.
Yeah.
And so, we are almost kind of a public entity. And the more that you take out of it, you might say, oh, this is great. We're going to save, 5% if we take this out of the hospital and move it somewhere else. But then it just expands all the stuff and the complicated stuff, the complex stuff has to be provided at the hospital.
Yep, absolutely.
Trauma care.
Another area I'd like to get your thoughts on is primary care. There's been a lot of articles that have come out recently that obviously it's been happening over the last couple of years that there's been a shortage in primary care. But more recently, there's been an article that 40% of some of the primary care services are being served in some markets by advanced practice providers, and it does create some consternation in a market that has strong primary care physicians. But in other markets where primary care is experiencing a real shortage, that's been an opportunity to be able to fill the void. And what we've also seen in other markets is that telehealth has really been used to at least provide some level of primary care. It certainly is not taken the place of it, but it's at least provided some basic levels of primary care. What are you seeing in your market?
So we have some excellent, stable family practice MDs here that serve our population. We also do have a fair amount of advanced practice providers that also do primary care here in our community. So in our area, being kind of a hub in Western Nebraska, our family medicine group seems fairly stable.
Yeah,
I would tell you a lot of the smaller communities that have critical access hospitals around us, a lot of them are much more heavily reliant on the advanced practice providers because they don't have any physicians out there. So there is, I think you're seeing, and I think just with the economics, you're going to see more and more of an emphasis on APPs providing that care in the future, and being subsidized with. There are a lot of telemedicine services now where some of the basic stuff you can go and get the visit that you need, have them prescribe you a medication or whatnot through.
right.
So I think you're going to see both primary care, telemedicine, kind of primary urgent care visits go through telemedicine, and I think you're going to continually see the expansion of advanced practice providers, both physician assistants and nurse practitioners.
Well, knowing what I know about Great Plains Health and North Platte, whether it's intentional or unintentional, you've done a great job of creating alignment with your primary care physicians and establishing that physicians as the core of primary care services. And then it seems like then you've been able to provide additional support through alignment with APPs and even utilizing telehealth. And that certainly can be a lesson learned for some other organizations who maybe have not taken that type of an intentional role. And it is a challenge. It is a challenge for many rural healthcare providers, because at the end of the day, care starts with primary care. And you need to have that. So, Ivan, this has been fantastic. I really appreciate all of your insights. For some of our listeners who do work in rural healthcare communities, whether they be physicians or administrators, any pieces of advice, words of wisdom you might want to share with some of your colleagues?
Well, I think with any organization, any business, I think you really need to sit down and decide, for our organization and our community, what are we really going to be the best at? And so we've tied being the best at to kind of our core service lines. And so we're going to have great primary care here, but we've essentially said that being a regional leader, we're looking at cardiology, oncology, orthopedics. Those are kind of the specialties that we should be great at in a community our size, and then provide that service in the communities around us and back here. Now, I'm going to tell you that as a critical access hospital that I ran, what I was going to be the best in the world at was very different than what I'm doing now. And
Sure.
So I think there's kind of this balance of taking a look and being very pragmatic about, what can we be the best at, and then really go all in on doing those things and being the best in that area and arena. And I think that for anyone running a health system, a hospital, an insurance plan, or anything else, that's something that they really need to look at and say, okay, how do we become the best at what we can be the best at, and go after it.
I agree. Just great advice. And I think, hearing you go over some of those key things, I think in my mind, it comes down to three things that frankly, you've done really well. I think identifying what services, like you said, you want to be the best at, right? And focusing attention on those service lines. But the other two things that really caught my attention was how you're collaborating with other critical access hospitals and even really pushing the payers to help understand what the challenges are. And then the third thing, which I think is certainly a key to the success, is your physician alignment strategy. That I think has been great. So I want to thank you for your time today. This has been fantastic. I'm sure our listeners really appreciated all of your insight, and best of luck to you. And I'm sure your organization is going to continue to do well.
Thank you, Dan. It was a pleasure.
I want to thank everyone for listening to another episode of Value-Based Care Insights. Until the next insight, I am your host, Daniel Marino, bringing you 30 minutes of value to your day. Take care. Have a great day.
Are you at a crossroad with value-based care? Do you need to chart a future strategy or improve your organization's performance? Visit us at luminahp.com to learn more about our professional advisory services and leadership development programs. Also, you can sign up for our newsletter on our website and follow us on Twitter and LinkedIn. To connect with Daniel Marino or for more information about the show, visit our website or healthcarenowradio.com. Join this conversation using our hashtag VBC Insights. We are Lumina Health Partners. Thank you for joining us today. Until the next Value-Based Care Insight, stay well.